So the second case makes me sad, and the title kind of infers that. The reason being is that this patient, when he came in and he saw the student, he said that he didn't even want to be dilated. So the student came up to me like kind of all flustered about it because they're like, oh my God, I'm going to like fail this encounter because this diabetic patient doesn't want to dilate. But I went in there, convinced him to dilate, and then the student took photos, and then the student came back to me and said, after I took the photos, the patient refused to even look at the photographs, right? So you just get this like sinking feeling in your heart that the patient's like not going to follow through with your recommendations. But the outcome of this case is good. Somewhat sad for me just to present from the beginning. So this is a really young patient, a 29-year-old American Indian male. He's coming in just saying he wants glasses and he wants to get out, basically. He's been already previously diagnosed with severe non-proliferative diabetic retinopathy at his eye exam 5 years ago. He's had diabetes for a very long time. We think it was type 2 versus type 1, but the age of onset, makes me think maybe it actually was type 1. I don't know. His hemoglobin A1C, 8.2%, so definitely could be better controlled. He's already had some amputations and, he's so young. His best corrected acuity is reduced at 20/30. And so here are his clearest images. Over here on the left is just a single wide field shot. And then over here on the right is his auto montage, which is a montage of 4 separate shots. And we can already appreciate that there is some neovascularization. It looks like elsewhere, particularly this large front here in the superior temporal arcade. But there's also a lot of diabetic retinopathy lesions and these dot blot hemorrhages out in the periphery that we're able to image really nicely. And just kind of zooming that up here, we can see he has this area of neo, he has this area of neo, he has this area of neo, and this area of neo down here. And then it also looks like some neovascularization on the disc. OCT angiography montage, this is a 14 millimeter by 14 millimeter montage scan here on the right, shows us the vascular detail really beautifully. And so we're able to see all this non-perfusion, right? And if we look over here on the color fundus photograph, there's nothing there that's cluing us in that this retina is non-perfused. But we're able to see that now with OCT angiography. And he's got a lot of it, right? I mean, there's a ton of non-perfusion kind of up in here as well. It really helps highlight those areas of neovascularization. And you can kind of tell already that the foveal vascular zone looks larger than it probably should be. It's almost one disc area in size, which is pretty unusual. And just to put that in perspective, for those of you who are new to OCT angiography technology, so this is a normal patient, what the peripheral capillary perfusion should look like. And then here's our patient that has, this massive areas of peripheral non-perfusion, and this enlarged foveal vascular zone that you can already appreciate on the montage image.
That used to be a big, I will say, stepping stone between angiography and color pictures from when we didn't have OCTA. If you just look at the macula itself, getting that shot of foveal avascular zone is very precious and is very helpful. And also to educate the patient. If you just show a color picture and they see few bleeds, but it's very different to show that dark black contrast and say how much of the retina is actually dead and is just actually creating VEGF.
Yeah, I agree. It's really powerful as an educational tool to show the patient if they'll look at it. Right?
Yeah.
And so here's his macular OCT. This is just a high resolution scan here right through the center of the fovea. You see there's no cystic fluid in the center of the fovea here. We can appreciate that there's some of fibrous tissue on the posterior hyaloid that's kind of hanging like a hammock across the cup, which is some neovascularization on the disc. Pretty classic presentation on the B-scan OCT here of neovascularization of the disc. So why does he have 20/30 vision if he doesn't have any center-involved diabetic macular edema? And the answer is macular ischemia, right? And so this is a 3 millimeter OCT angiography macular scan. So we're getting really high capillary resolution detail of the foveal vascular zone. And so a normal foveovascular zone should have this ring of perifoveal capillaries that's intact, right? Versus our patient where he has these breaks in this perifoveal ring that signify some ischemia and some irregularity. There's certainly an irregular contour to his foveovascular zone. It's larger than what we'd expect a normal patient to be. This is a 4.5 millimeter OCT angiography cube scan of the optic nerve head. And so you would use this scan to visualize neovascularization of the disc in greater detail and higher resolution. And so what we can see here is this patient has some really extensive neovascularization of the disc. And the vitreoretinal interface, or the VRI, it's a preset display on this particular scan on the Zeiss Cirrus model software, the vitreoretinal interface display is specifically designed to show you preretinal neovascularization or neovascularization of the disc. So if you have someone that you suspect has neovascularization, make sure you're looking at the vitreoretinal interface for neovascularization. I also want to point out just the beautiful detail that we get of these neovascular complexes with OCT angiography. So OCT angiography, the capillary detail is better than fluorescein angiography because there's no leakage that obscures our view. So because this patient has obviously high-risk proliferative diabetic retinopathy, the NBD area is at least like 2 to 3 disc areas in size, if not more, certainly would classify this as high-risk proliferation. No macular edema. My preferred treatment option would be PRP. We referred to retina and they ended up doing PRP actually in both eyes. Both eyes look pretty similar for this guy. He's so young, we know he's non-compliant, and we need to get some permanent laser solution in there. Manish, do you think that your retina specialist would have managed this any differently?
I agree with you. PRP is definitely recommended, as you can see, American Academy of Ophthalmology guideline is. But as we know more about anti-VEGF and how they help in kind of making the retina dry in a better way, the laser uptakes are better, especially this patient with all that non-perfusion area, which is just an area kind of pumping out VEGF on a constant basis. It's nice to have it lasered and calm down. I wouldn't be surprised if the approach would be to just give some anti-VEGF injections to just calm the eye down a little bit and then follow it up with the PRP. Yeah.
Agreed. I think probably a combination of the two is best, right? So like hit it hard first with an anti-VEGF agent, but then make sure you get your PRP in there like long term to kind of hold them steady and through. One of the really important things I think to look at when you're doing OCT angiography montage is there non-perfusion out in the mid-periphery and the periphery? And if there is, how much? And so we can see on these diabetic patients, the non-perfusion is not in the posterior pole, right? The majority of it is taking place out in the periphery. We need to be able to image that, and OCT angiography montage is the way that we're going to do that. When you see a patient that has massive non-perfusion, like this one over here on the right, it's telling you that if they're not already proliferative, right, that there's an increased risk to go on to progress to proliferative disease, and that they would likely benefit from early treatment, whether that's PRP or that's anti-VEGF treatment. And so for patients who are kind of like in this bucket where they're not yet at high risk proliferation, where everyone agrees like, yeah, you definitely got to treat that. Let's say maybe they're severe non-proliferative or they're low risk proliferative. They don't yet necessarily have to have treatment. When would you maybe sometimes treat them early? I think if you're seeing a patient like this on OCT angiography montage that has a lot of ischemia, we know they're at high risk to go on and progress. That's somebody you're more likely to treat than not.